Hi, everybody. Thank you so much for joining us. We'll get started here shortly. We're just going to wait for a few more people to get into the room. Hi there, everybody. Thank you so much for joining us. We're just going to wait a few more moments for some people to get into the room before we get started. Welcome in, everybody. We're going to get started here in just a few moments. Just going to wait for some more people to get in. All right. Looks like we've evened out here. I think we can get started now. All right. Hi, everybody. My name is Chris Pennell, and I'll be moderating today's webinar. Welcome to the Behind the Scan webinar titled Putting Pediatric POCUS into Practice. Before we begin, I just have a few things to cover. All webinar attendees are muted. Due to previous commitments, we will not have a live Q&A as usual. However, we will still be taking questions. If you're on the main Zoom stream, you can type your questions into the Q&A box in the toolbar located at the bottom or the side of your screen, and feel free to enter them throughout the presentation, and they'll be passed on to be answered. For those not on the Zoom stream, you may send your questions to Paul Bajarski at paul.bajarski@fujifilm.com. Paul will then forward your questions along. This webinar will be recorded and archived for future reference on our webinars page. Here with us today, we have Dr. Marla Levine. Dr. Levine is an associate professor of pediatrics in the Division of Emergency Medicine at Monroe Carroll Jr. Children's Hospital at Vanderbilt, and the director of point-of-care ultrasound within their pediatric emergency department. She's been recognized as a leader in PEM POCUS, particularly as an educator in emergency ultrasound, regionally, nationally, and internationally. She has authored numerous papers on the utility of POCUS in the care of pediatric patients, as well as helped create educational guidelines for how to incorporate POCUS into educational curricula. Dr. Levine currently serves on the executive committee for the P2 Network, the International PM POCUS Collaborative, as the chair of global health. Dr. Levine, thanks so much for being here. I'll go ahead and turn it on over to you.
Well, thank you so much, Chris, and thank you so much to Sonosite for inviting me today to speak and giving me the opportunity to share with you all about why I love ultrasound so much and how ultrasound has been really critical and invaluable for me in my journey in pediatric emergency medicine and in the care of my patients. And so I hope throughout this lecture, you're really going to get an understanding for how we can use point of care ultrasound in pediatric emergency medicine. And I would argue just in terms of whoever is visiting with us today, pediatrics in general, in terms of how we can use point of care ultrasound in the care of children, because this technology is really, really helpful throughout the whole clinical landscape of the care of children. This talk is going to be a case-based lecture, so we're going to go through various applications in point of care ultrasound using cases to demonstrate how we can use this technology in the care of our patients. So starting out, chapter 1 is skin soft tissue ultrasound. And for those of us who have been using ultrasound in clinical care, we understand that skin soft tissue ultrasound was really how we began to understand that this could really change how we cared for patients. The earliest prospective studies in point of care ultrasound looked at skin soft tissue ultrasound, and this really helped us understand that this could have clinical significance at the bedside and allow us to take better care of our patients by understanding at the bedside how we should be managing our patients. So with that, let's start. So this was a case of a 2-year-old male who presented to the emergency department with left hand swelling after being bitten by a spider on the night prior to presentation. He had been afebrile, he had full range of motion at his hand. And what you can see in this picture is that he had really, really very, very impressive swelling of his hand. He had bright cellulitis appearing, redness to his hand. He had circumferential swelling. We demarcated that area of redness. And then if you can see right at about his wrist, right over here, you can see this was the area where he had been bitten. But with the aggressiveness of the spread of redness and the degree of swelling, it was actually pretty hard to sense as to whether or not there was an underlying abscess in there. And this is where we were able to use ultrasound to help guide our management. So grabbed the ultrasound machine and did a bedside ultrasound. And what we were able to see is that when we put the ultrasound on this child's hand, we were able to see the signs, the sonographic signs of cellulitis. So what we can see is this cobblestoning appearance of the subcutaneous tissue. You can see those lakes, those anechoic, those black lakes of fluid that are coursing through the subcutaneous tissue. And that is consistent with edema, swelling, and that appearance, that kind of cobblestoning or cottage cheese looking appearance of skin is consistent with cellulitis. And we were effectively able to rule out an abscess in this child, and we were able to initiate the appropriate management for this little guy. This next case is a case of a 15-year-old male who presented to the ED with a painful mass to his left arm. He stated that this mass started as a small lesion 3 days prior to presentation. He's been afebrile. He's been freely able to use his arm. He's been ranging the arm appropriately. We can see on exam that this looks consistent with an abscess. We can see that it looked quite fluctuant. It had that boggy appearance. So we knew, I mean, you can see that this looks consistent with an abscess. But what's nice is when you use ultrasound, and here's what the ultrasound looked like. When you put the ultrasound on the arm, you can see that we have this kind of swirling presentation of the contents within the abscess. It looks ugly, which abscesses typically look kind of ugly. You can see this kind of rim of kind of the abscess collection. But what's nice with doing an ultrasound before you do any interventions with an abscess is, in addition to confirming the presence of an abscess, you can also ensure that before you do any interventions that you're not going to cut into any important other anatomy. So for example, you are not in it, that you can confirm that you're not in any close proximity to any important blood vessels, that you are not in close proximity to any nerves. You have essentially confirmed that it's safe to actually do a drainage. And so in addition to confirming the presence of an abscess, you are also confirming that it's safe to actually do the intervention that you need to properly manage this condition. This was a great case. This was a colleague's case. This is a 7-year-old male with a foreign body sensation to the plantar aspect of his right foot. The child stated that his sibling had dropped a glass in the kitchen floor. It shattered. Family tried to clean up the glass, but this child walked in the kitchen and subsequently had the sensation of foreign body in his foot. There was no outward appearance of any foreign body on the plantar aspect of the foot, but the child had the sensation of the foot, of the foreign body in the foot. Now, my colleague put the ultrasound on the child's foot, and lo and behold, what we see is the image on the left looks exactly consistent with the image on the right. So this was the foreign body that the child had stated he felt. And following the foreign body removal, we can see that exactly what the child felt and what we see on ultrasound that my colleague had identified, he was able to physically remove from the child's foot. Okay, so ultrasound is fantastic for foreign body removal. We love it. Now you might be thinking, yes, but Marla, X-ray could identify this, and we could have also proven that this child had this glass in the child's foot, and I would say 100%. Glass and metal will appear on X-ray, and I agree with you. Where ultrasound wins over X-ray is that ultrasound can also identify radiolucent foreign bodies. So let's say this child had a splinter in his foot. Ultrasound would have seen that splinter because the splinter would have also appeared brightly hyperechoic, like this glass is hyperechoic. It's very, very bright. splinter or wood or plastic would have also appeared brightly echogenic or bright. And so where ultrasound wins is that in addition to picking up structures or foreign body material like metallic and glass foreign bodies that X-ray also would pick up, it also will pick up the radiolucent foreign bodies. And then as an additional step, as you can see, this foreign body, my colleague was able to identify the presence of the foreign body, and then he was also able to identify exactly the depth of the foreign body. And just like with abscess drainage, she was able to confirm that it was not in close proximity to any other important structures. So he could use this for planning of the foreign body removal. So you can use this for procedural guidance as well. And so this was really, really a wonderful example of how we can use ultrasound, not only for confirmation of foreign body removal, but for procedural guidance. This is a case of a 3-year-old female who presented to her pediatrician's office with right-sided neck swelling. She had had some nasal congestion and cough for the last 7 days. And then began having this neck swelling. She had full range of motion of her neck. There was no concern for meningitis. She had no meningismus. She was non-toxic appearing, but she had this neck mass. And so she did have some tenderness to palpation along the neck. So when we put the ultrasound on her neck, I apologize, the clip is a little bit stop and start, but you can see what comes into view are these kidney bean-like structures that are coming into view, and those are our lymph nodes. So what this child had was a conglomeration of lymph nodes. That was the neck mass. And because she had tenderness over that area, this would be consistent with more of a lymphadenitis picture. She was treated with antibiotics, and like in all situations, things can develop. So she was, the recommendation was to come back in case there was any concern that this was not improving. And obviously, we did not see any abscess on our original pass with the ultrasound, but obviously, if there was any kind of concern that this was not improving with antibiotics, then we would have, again, scanned her neck with the ultrasound and then further explored if there was any concern that this was not improving with antibiotics. But this was 100% consistent with normal appearing lymph nodes at that time. Unfortunately, I don't have a clip of color flow Doppler. That would have been another way to show that these were healthy lymph nodes, because with healthy lymph nodes, you can see the color flow Doppler at the central hilum, at the inner aspect of the lymph nodes where they get their nutrition. You will see the blood vessels come into the lymph nodes. Unfortunately, you don't see it in this clip. That's another kind of proof that these are healthy lymph nodes. And so at this pass, though, however, these were consistent with healthy lymph nodes, just inflamed lymph nodes consistent with a lymphadenitis picture. This next case was a case of a 25-month-old female with complex medical history, including liver transplant, secondary to biliary atresia. She presented to the ED cachectic and dehydrated, and unfortunately, given her degree of toxicity, the nursing team was unable to establish IV access using landmark technique. Now, in our shop, we have formidable nurses who've become ultrasound IV champions. And one of our fantastic nurses, he was able to secure an ultrasound guided IV on this little girl who had very challenging anatomy. And here is an example of a very, very small vein that he was able to cannulate, this little guy over here. This is in live cannulation. And here is, so this is in the short axis. We can see the cannula going into the IV. And then this is the long axis. We can see the catheter going through the vein after he secured access. And what's wonderful is that in many, many children's hospitals now, this has become a nursing directed intervention where nurses are leading the charge in ultrasound guided IVs. And this has really changed management, improving the care of patients. And it is a wonderful intervention that has led to really improvement of care, quicker access to IV placement, and is a real wonderful intervention since the advent of point of care ultrasound. Chapter 2 is the FAST exam. The FAST exam really revolutionized trauma management. So it used to be that part of the trauma algorithm in the acute trauma life support algorithm in yesteryear, there used to be something called the diagnostic peritoneal lavage, and this is how we used to interrogate the trauma patient for any kind of bleeding within the abdomen. It was an invasive procedure where you would actually have to instill some fluid inside of your patient and then essentially withdraw fluid from your patient. You would basically put a needle inside your patient, then withdraw that fluid to see if there was any bleeding within their abdomen following a traumatic injury. That was invasive, and thankfully we don't do that anymore. That was actually replaced in the trauma management algorithm with the FAST exam. The FAST exam stands for the Focused Assessment with Sonography and Trauma. And this was a real kind of game changer with the trauma algorithm protocol for our in our trauma algorithm in all emergency department management. This is a case of a 5-year-old female who presented to the emergency department following a motor vehicle accident just prior to presentation. The front to the car was impacted at a speed of approximately 45 miles per hour. There was positive airbag deployment. Good news for the child, she was properly restrained in the back seat in a toddler seat, and she denied any pain or discomfort following the accident. She had no signs of injury on trauma evaluation. And as part of the protocol, after the primary and secondary survey, she actually had some trauma labs done. We did a FAST exam. And so in the FAST exam, we interrogate all the dependent regions of the body, looking for sources of bleeding. So the first location that we interrogate is the pericardial sac, which is essentially, we're looking at the heart. We're looking for any bleeding that could have happened from an injury to the heart, looking at the dependent area of the heart. So there was no bleeding to her heart, or no injury to her heart, as evidenced by a lack of any pericardial effusion. We then move to her right upper quadrant in Morrison's pouch, looking at the hepatorenal recess, looking between the liver and kidney to see if there was any bleeding in this space. It's always a good idea always to extend and just make sure you don't see any bleeding in the base of the lungs. We're going to go through that in the next section, which is going to focus specifically on the lungs, but making sure that there's no bleeding at the base of the lungs, which would be just over the diaphragm. We then go to the left side of the child's body. This would be the same protocol for adults as well. We're looking at the splenorenal recess here, looking for any fluid that could have collected between the spleen and the kidney. Also trying to look under the diaphragm, between the spleen and the diaphragm. We also want to make sure that we're always looking near the tip of the kidney as well, just making sure that fluid is not hiding, and then again looking at the base of the lungs as well to make sure that there's no hemothorax. And then we move to the pelvis, looking at below the bladder. We usually will scan in 2 orthogonal planes, both in a transverse and in a sagittal plane. That means we look both with the probe marker pointing towards the patient's right and towards the patient's head. Again, just making sure that we have done our due diligence to ensure that there's no free fluid or bleeding within this child. Now, just as a point of information, in your pediatric patient, the most sensitive location for free fluid or bleeding injury in a child will be this pelvis location. This was an amazing case of a 15-year-old male that we saw. He was a victim of a gunshot wound. He had actually been struck in the right upper abdomen. He had no exit wound on his ballistic survey. Amazingly, he had a chest x-ray that was negative. And he had normal vital signs. He looked great. He was deceivingly stable. It was jarring how stable he looked. But given the location of the entry wound, a colleague called me over to do a FAST exam. And on the FAST exam, we actually realized that this was actually, he was a ticking time bomb, because he actually had a very large pericardial effusion. He was actually in impending pericardial tamponade physiology. It was based on the FAST exam that everything got kicked into high gear, because we realized he actually was not stable at all. He actually needed to go to the OR very expeditiously. The CT surgeon was called in. The child went emergently to the CT scanner. The OR was booked, and everything was done very, very quickly after we saw what was truly going on with this child, and this was life-saving. This is a case of a 6-year-old male who presented to the ED following a motor vehicle accident, presented with a normal neurologic exam, had a positive seatbelt sign, so clearly he had an injury to his abdomen. He did complain about belly pain on exam. We do trauma labs as part of all of our trauma evaluation. And given the fact that he had complaints of abdominal pain, he had signs of injury, he was going to be going to a CT scan to be further evaluated. So on the initial FAST exam, he did have evidence of intra-abdominal trauma. So there was a positive FAST. You can see that there is, as opposed to the previous examples where we saw no free fluid in the hepatorenal recess, meaning in the previous example, the kidney-liver interface was tight. In this example, you can see that there is an anechoic amount of fluid that's tracking between the two organs. That is blood. So that means that there is bleeding. Now, what's amazing that we can do with the ultrasound that you would not want to do with any other imaging modality because of the risk of ionizing radiation, and you would not want to do unnecessary repeat imaging, because ultrasound exposes your patient to no risks. I mean, this is the safest imaging modality that we have. You can repeat the ultrasounds as much as you want. So when this child came back to the department after a little while, we were able to repeat the ultrasound and see that there was actually expansion of the bleeding. And you will see over time, if there is bleeding, you will see worsening signs on the FAST exam, worsening bleeding, worsening collection of free fluid. Then ultimately this child went, this was actually a liver lac. So the child actually did not go to the OR, just went to the PICU for management. Okay, chapter 3, the lung ultrasound. For many of us who do ultrasound medicine, lung ultrasound is one of those like favorite applications, largely because it's always nice when you can have an application where ultrasound is better than other imaging modalities. And that's one of the areas where really ultrasound shines when we talk about lung. Because where ultrasound and CT scan are comparable in their test characteristics, ultrasound is often more sensitive than X-ray. And obviously we don't want to do CT scans on most of our patients, and X-ray tends to be that imaging modality that we get more than any other imaging modality when we're interrogating the lungs. It's nice that we can look at X-ray as compared to ultrasound and know that in most situations, ultrasound is going to be even better than X-ray. This is a case of a 14-year-old male who presented to the ED with acute onset of left-sided chest pain after band practice. He placed the trombone. He arrived to the ED. He wasn't in respiratory distress, but he had that chest discomfort. And on the right side, what we can see is this is what the ultrasound of the chest looks like. So when we talk about lung ultrasound, the lung looks different sonographically than other organs, because you're not going to see something that looks like the lung unless there's a lot of fluid there. So unless there's a disease in the lung, you're not going to see lung tissue. But what you see over here is because the lung is a dynamic organ, you're going to see movement, because as you're breathing, there's going to be signs of movement. And this is what the pleura looks like as it's moving. You're breathing, and so the visceral and parietal pleura are going to move against each other. So this is a rib over here, and the pleura that's moving. Now, on the left side of his chest, there was no movement of pleura, right? This is what we can see over here. The absence of lung sliding is highly suggestive of a pneumothorax. Now, it's not 100% specific, but it's highly suggestive. Now, there is a differential. Obviously, it could be a right main stem intubation if your patient is intubated. Maybe your patient's already had a pleurodesis, so it could mean that this child has already had a pneumothorax. But in this clinical context, it would obviously be highly, highly suggestive of a pneumothorax. So as we continue the case, I was scanning, and I started, so with pneumothorax, obviously it's going to go from the point of least dependent to the point of most dependent. So when you start off, you're going to see it most likely is you're going to see it apically, and then you're going to scan down. So as I was scanning, I saw lack of lung sliding the higher I was. And as I scanned down, I started to see the interface of the lack of lung sliding and the presence of lung sliding. So over here was actually that interface where we found the point where it popped, where the bleb was located. And that's right over here. And then on X-ray, you can see that it was right over here was the pneumothorax. And so it consisted, the X-ray was completely corresponded. I mean, I had the ultrasound way before we had the chest X-ray, which was nice because I was able to already tell mom what the plan was, and we were just now waiting on kind of the next steps, which were to get the chest X-ray and then get surgery. But put him on some 100% oxygen, got him comfortable, and then we were able to take it from there. So the nice thing with ultrasound is that if you know how to use it and you know how to interpret it, then you are relying on yourself to capture the imaging, to interpret the imaging, and then you're not waiting on radiology or whether it's chest X-ray to come to the bedside or radiology to interpret. You're kind of doing it all on your own, which is really the nice and empowering thing about the use of point of care ultrasound in your practice. This is a case of an 8-year-old male with a history of nephrotic syndrome. He presented to the ED with report of shortness of breath. He had an oxygen saturation of 92% and a respiratory rate of 32. So this child was clearly he was showing signs that he was in respiratory distress. He was breathing fast. I had a suspicion that he was going to be fluid overloaded. And lo and behold, when we looked at his chest, we could see something was wrong. So as I mentioned earlier, you should never see anything within the thoracic cavity because it is filled with air. I didn't say that a second ago, but I just said that you won't see the lung because it's going to behave differently than other organs. So now as I kind of go into it, because most of medical imaging, you're looking at tissue, and most tissue has some degree of fluid in the tissue, which allows us to actually see that tissue with ultrasound. We can interpret it, right? So we see over here, liver and kidney, these have varying degrees of liquid density, right? And it'll interact with the ultrasound beam, and you can interpret that. The lung is filled with air. Air and ultrasound don't interact the same way. And because they don't interact the same way, what happens is in a normal situation, like the image on the right, what should happen is that you should have complete darkness in the chest cavity because the air and ultrasound beams don't interact. It results in this kind of diffraction picture with the ultrasound air interface of the molecule, the ultrasound beam and the molecule, such that you don't get any kind of meaningful information back. In fact, for a very long time, it was believed that air is the enemy of ultrasound, that you can never image through air. We now understand that we can. We just had to interpret it differently. But so in this example, you can see in the thoracic cavity, right, you have a complete absence, darkness above the diaphragm. This is the diaphragm that meets the spine, and you have darkness. In this situation, actually, darkness is good. Darkness means you don't have pathology. You don't want to see anything north of the diaphragm. This is good. You should not see anything. In this example, however, what you can see is you have the liver, you have kidney, you have diaphragm, you have spine, and you see that spine go north. And you see darkness that looks different. This is fluid darkness. This is actually liquid darkness. And this has actually created an acoustic window through which that sound beam, that sound energy can now travel through the thoracic cavity and actually propagate those sound waves to the spine and allow now the spine to light up. And now you can actually see within the thoracic cavity, you can actually see information. Unfortunately, if you can see things within the thoracic cavity, it means that there's pathology there. And in this case, you have all that liquid within the thoracic cavity. Here it's pleural effusion, lighting up the spine. You even can see a bit of the lung that's flapping around in there. That's atelectatic lung. So this is a case of pleural effusion. So this is an example of what we call spine sign, pleural effusion, and you see atelectatic lung. This is a case of a 7-year-old male, 4-month status post-cardiac transplantation. He was presenting to the ED with respiratory distress. The child's noted to have a respiratory rate of 40 and an oxygen saturation of 91%. So we're going to do a side-by-side again. So with this little guy, we see something over here that's a bit hard to interpret if you've never seen lung ultrasound, but we're going to go back there. This is what we call pulmonary edema. It's B-lines. You know what pulmonary edema is. It's fluid overload. It's interstitial edema. But this is what pulmonary edema looks like sonographically. And it's because you have a bunch of B-lines, which is, it's a manifestation called reverberation artifact. And all of these B-lines have coalesced, and you basically just see basically a whiteout picture as you're scanning. And that's because there's so much interstitial fluid that from the pleura, which starts over here, all you see are now all these beam-like B-lines have coalesced, and all you see is basically fluid. This is a manifestation of fluid. Now, by comparison, this is what a normal lung looks like if you're looking at the pleural line. You can get one B-line here, one B-line. So 2 B-lines in any region is non-pathologic. Here's the pleural line, here's a B-line coming into view, and then another P-line coming into view. But what you should see is these kind of horizontal lines, those are A-lines. You should see those, actually. That's another example of an artifact, but you should see this kind of picture, the occasional horizontal line, maybe the occasional vertical line, and then just the pleura. If you can't see anything but these strobe lighty conglomeration of B-lines, this picture is in a lot of interstitial fluid consistent with pulmonary edema, and that's what this kid had. This is a case of a 2-year-old male with 1-week history of cough and congestion, and he had a diagnosis of RSV at the onset of illness. Now he's presenting to the ED with a temperature of 103.2, a respiratory rate of 46, and saturating 93%. So now that you've had an explanation of normal versus abnormal thoracic cavity appearance, already you should see that this doesn't look normal. Because right over here is the liver. The diaphragm is coming into view over here. This is the spine and it's going north of the diaphragm. And what it looks like is you have liver, and then it looks like liver is on top of liver. And we know that that doesn't happen. So this liver-like consistency organ that's sitting above the liver is actually what the lung looks like if there's pneumonia in the lung. We call this hepatization of the lung, and this is what the sonographic appearance of pneumonia looks like. And you can also see that there is the extension of the spine because there's now fluid, and we have fluid inside the lung. It'll light up the spine. And this is pneumonia. Now, again, for comparison's sake, so looking at it side by side, you can see this is, again, healthy lung. You have the liver, you have the diaphragm, you have spine, and you see nothing. So side by side, it should really be quite convincing that this represents pathology and this is healthy. Okay. Chapter 4 is pediatric abdominal ultrasound. So while those other applications were, for those of us who've been doing point of care ultrasound, those were brought over to us by our adult emergency ultrasound counterparts. Whereas the pediatric abdominal ultrasound, this is unique to us. Our adult counterparts may do this on children if they're working in general emergency departments. But for those of us who work in peds, this is what, if we are in centers that will, sometimes, depending on where we practice, we may be using a lot of this and working with our surgeons to help in really expediting care of our patients who may be coming in with clinically concerning pediatric abdominal pathology. This is a case of an 18-month-old female who presented to the emergency department with intermittent crying spells and vomiting and periods of lethargy. So just by the clinical scenario, this sounds very concerning for intussusception. And on ultrasound, in scanning her belly, lo and behold, what we saw was this targetoid lesion that did pop up right under her liver. So when you do an intussusception ultrasound, you're basically tracking from the right lower quadrant all the way to the left lower quadrant, you're basically lawn mowing with your linear probe, tracking the large bowel, looking for this targetoid lesion. And it's going to have, if it comes into view, it's going to be greater than 2 centimeters in cross-sectional diameter. And it will, if you do a second pass, it'll still be there. It's not going to self-reduce. And if it's present, it needs to be reduced. So if it's there, you're going to have to be working in concert with your pediatric radiology subspecialist to have the child undergo appropriate either air or barium reduction. This was a case that I had of an 8-year-old male who presented to the ED with 36 hours of abdominal pain that migrated to the right lower quadrant. He had had 3 episodes of vomiting and low-grade fever. What was so nice with this case is that, yes, this child had signs and symptoms that were 100% consistent with appendicitis. We brought him into the room, and even before he had been registered, I was able to capture the image on the left. And you know, in certain times, there was a time where surgeons would take children to the OR just by clinical exam alone. And I would argue this kid had a history and an exam that was very consistent with appendicitis. But I would say that we're now working in an era where most people require some form of imaging to take a child to the OR. And what was nice is that I was able to capture the imaging that confirmed the presence of appendicitis. And then even before the child was registered as a patient, I was working in a shop. This was in a previous job where I worked with my surgeons. I was able to send the surgeon a screenshot of the image that I captured with obviously a little bit of information about the child. He saw this, booked the OR, and then an hour and a half later shot me the image on the right. And so this was this kind of beautiful example of how, with the right understanding of how to use this technology, not only is this going to help in clinical care, and it's obviously a huge satisfier to families, but it also really helps in patient throughput and the benefits down the line in terms of everyone who is helped by point of care ultrasound from a hospital level as well. It doesn't end just with you and the patient. It really is a systems benefiter. And so I just love this because it's not every day that a surgeon will send you a picture of the inflamed appendix and it just looked so beautiful side by side. So I really love this case. This was a case of a 6-week-old infant, male infant, who presented to the ED with a report of 3 days of projectile vomiting. The infant was otherwise well appearing, no fever, no viral symptoms. He appeared hungry and interested in feeding. And for those of you who remember, the hungry vomiter is very, very classic story for pyloric stenosis. Often with these little ones, they're vomiting so much that with an empty stomach, often you can't see the pylorus very clearly because it's usually deflated, and they often will cry and swallow air, and it can sometimes be very challenging to see the pylorus. But for some reason, we were able to capture these beautiful, beautiful images of this pylorus. And what you can see is here is the stomach that's quite empty, but we can see this very hypertrophied pylorus. And what you can, I hope, appreciate is that there's actually the lumen is so hypertrophied, like the whole pylorus is so hypertrophied that there actually is no lumen here. You can appreciate that there will be no ability for outflow of contents from this pylorus. You may or may not remember that there's certain size parameters for the diagnosis of pyloric stenosis. So you need to have a channel length greater than 14 millimeters and a wall thickness greater than 3 millimeters. And that was what we were able to confirm when we actually measured the pylorus on this child. Chapter 5, POCUS and global health. So I am very understanding that in the Western world, we have many options for imaging. And while I'm obviously a great believer in point of care ultrasound, we have a lot of resources. And so while we can use point of care ultrasound, we have many, many ways of making the diagnosis with our patients. Where I have been so incredibly humbled is when I have been able to use point of care ultrasound in the global health setting, where I really appreciate that sometimes this is the only imaging modality that we have. And this is where this could be the difference between life and death. And I think for anybody who is exploring the potential of working in a global health setting or in austere environments, this is invaluable to your practice. Obviously, I'm a believer in using point of care ultrasound regardless of where you practice, but I have really been so grateful for this training in order to help patients in settings where this is really all you have to help your patient. So on a medical mission, the last time I was in Haiti, unfortunately, was years ago, and obviously I have not been able to get back, but this was back in 2016. We did a medical mission. The actually purpose of the medical mission was an educational mission to teach providers at a children's hospital how to use point of care ultrasound to take care of their patients. But in the process, we actually went to do a home visit to a woman who one of the members of our team had met on a prior visit. She had been a woman, 29-year-old female with complaints of several months history of fatigue and shortness of breath. Actually, this all started after a few months after the birth of, or within weeks of the birth of her last child. She had no electricity in her home. The nice thing is that the earliest iterations of the Sonosite product, the M Turbo, who, if you're familiar with the Sonosite fleet of ultrasounds, the M Turbo, in spite of its age, is still an incredibly durable machine. It's still a great machine. It travels well, and it has a great battery life. So they were very generous in lending me a machine for this medical mission. And so in spite of the fact that this woman had no electricity in her home, we were able to work off of the battery of this M Turbo, and we started scanning. And so the first thing I did, given her complaint, was I looked at her heart. And unfortunately, in looking at her heart, I had the answer as soon as I looked. So you don't have to be a cardiologist to appreciate when you're looking at her heart that her heart looked quite diseased. Her heart was very boggy in its appearance. It didn't have much of a squeeze, which you can appreciate, and her mitral valve was not doing very much. So here's the mitral valve. This is the anterior septal wall, and that mitral valve is not making very much contact with the septal wall. So when we talk about ejection fraction, we're really talking about how close is that mitral valve meeting the septal wall, and the further away it is, the poorer the ejection fraction. So this woman had a very compromised ejection fraction. So she was in quite a significant degree of heart failure. She also had a little bit of a pericardial effusion, which you can see over here, but I would argue her main issue was her heart failure. She also had a really dilated IVC. So because her heart was failing so substantially, her IVC was quite plethoric. So the IVC should show respiratory variation. It should show a collapse of about 50% with each inspiration. And what you can see is that this is just a big plethoric IVC. It's not really changing with respiratory variation at all. It's just staying large and plump. There was a lot of hope years ago that the IVC could be used as a marker of intravascular fluid volume. Unfortunately, those studies didn't really pan out, but I would argue in the extremes, either in the very fluid overloaded and very fluid deplete, you can use that to get additional information on your patient. Her fluid overloaded state, given her lack of forward propulsion of blood, was quite evident. She had fluid everywhere, including, as you can see, here's her liver, diaphragm, spine going north of the diaphragm, and you can see she had fluid. She had just a little bit of pleural effusion and atelectasis because she had fluid everywhere. And she had ascites as well in her belly. She even had like quite a little bit of a belly distension because of her fullness of her abdomen. This was a set. I don't know what ultimately happened with her. She did not live close to Port-au-Prince. I don't know her ease of getting to Port-au-Prince. Obviously, Port-au-Prince being the main referral center, and she clearly needed a cardiologist. And I don't know what ultimately happened. The majority of our time for the medical mission was spent in the Children's Hospital. And as mentioned, the purpose of the mission was in education, working with the nurses and the staff at this Children's Hospital to give them the skills on how they could use ultrasound, because amazingly, in spite of the fact that they are they only had radiology twice a week. They did have an X-ray. There was one CT scanner in the whole of Port-au-Prince that was not on their site. It actually was down for the month while I was there. During the time that I was there, the CT scanner was down. They had a great machine on site. So really, truly, the limit for their use of the machine was just education. So I was really happy to be part of the process of helping them use the things that the equipment that they already had. We had been packing up on nearing the end of our medical mission. I think it was 2 days before the end of our medical mission, when a father came in with a 3-year-old child draped over his arms. And for those of us who work with children, especially in pediatric emergency medicine, whenever a child is draped over a parent's arm, it's kind of the international sign of potentially impending death. It's a really kind of critical and ominous sign. And the father came in with this child in that way. And for those of you who work in emergency medicine, you know that boarding is definitely a situation. It is also a situation in the developing world. And this was at the end of the day that we were packing up, and every bed in the whole room, I mean, it was not a huge emergency department, but every space had been occupied by a patient, and there was nowhere to put this child. So one of my colleagues, one of the local physicians, grabbed a code cart and wiped all of the tools that were on the code cart off the code cart, and we put the little girl on the code cart. Now, while they were in the process of doing medical resuscitation and attending to her, I grabbed the machine and started to collect information to help them. And so I started with a fast exam. So I first looked at her heart. I saw that she had good squeeze. Great. This was not heart related. Fantastic. I then did a fast exam because I didn't know if she had sustained trauma. So looked and ensured that she had no free fluid in her right upper quadrant. I then went to her left upper quadrant and ensured that she had no fluid there. I looked in her pelvis. Great. Nothing was there. Phew. Okay. So I ruled out heart and I ruled out trauma. I then looked at her IVC and something was suspicious. So now that you've looked at the last case where the woman had the plethoric IVC, now you can see this looks the complete opposite. So this child had a completely collapsed IVC. So a collapsed IVC is consistent with a depleted intravascular fluid state. So this child was, this was a piece of information that was not good. I still didn't know what was going on, but I knew that this was going to be helpful. And then continued scanning. I scanned her chest, and lo and behold, I found the answer. So we learned that this child had some respiratory distress. The child looked to be in distress. I saw that she was intravascularly depleted, and now we had this big, very, very impressive pneumonia. Okay, the picture was complete. She was in septic shock from this pneumonia, and we had our information. So while I was collecting information, the team was actually medically managing her, and I was just calling out information as I got it. So they had established IV access. What I didn't realize, because I was kind of focused on scanning, was they actually intubated this little girl. And I thought that was really interesting because it's not something that you see every day in the developing world. Why I say that is that in the Western world, we intubate often, no question. It's a different setting in the developing world. And I'm going to set the scene because we're in the emergency department. They intubated her. We're in the emergency department and we're on the ground floor. Radiology is also in the ground floor, and radiology comes in twice a week. You can get x-rays twice a week. The pediatric ICU is on the second floor. In order to get your patient from the ground floor to the PICU, you have to go up a ramp outside. So you have to roll your patient up a ramp. Once you get your patient up to the second floor, then they're going to be hooked up to a vent. Now, the vents that they have are not the vents that we have. The vents that they have are older vents. These are not the portable vents that we currently have. These are the older vents that we used to have, like 15, sometimes 20 years ago. These are the clunky old vents that you don't move patients with. Additionally, you physically can't move your patient because you can't move your patient in an old chunky vent down a ramp to get down to radiology. So what I realized after this child was intubated and once we got her upstairs is she wasn't moving. Once she got up to the ICU, she wasn't moving. That's where she was going to be until she was going to be extubated. And then I realized, well, I had just spent the whole week teaching them how to do ultrasound. So we had a way that we could actually get meaningful information. Even though we couldn't move her, we had a way that we could still image her. So the next clip is actually the clip from the actual machine that we did in the ICU in 2016. So you're going to see that in just one second. So here it is. So this is how we did this. So we used ultrasound, only ultrasound, to image this child throughout the course of her intubation for her profound pneumonia with respiratory failure until she was able to be effectively extubated. Now, I left the country 2 days later and they were on their own. They no longer had me there to be working with them. But what's nice is that WhatsApp is something that's used universally in a lot of these developing countries. And so I was able to still be in touch with them. They were able to capture images and shoot me these images via WhatsApp. And this is one of the WhatsApp images that they had sent me a couple days later. And it was really, this was a wonderful story of how ultrasound really was instrumental in saving the life of this child. I don't think she would have survived without ultrasound. I think the team became very empowered to use ultrasound in the care of this child. She ultimately was extubated. So it was a really beautiful story of the life-saving potential of ultrasound. And I was really, really humbled to have been part of that care team. And as I always feel, like ultrasound is really something that I am so very much invested in. I really think that it is something that can always help you in medical decision-making at the bedside. It can help you tailor your medical workup or your interventions, obviously in resource-limiting settings or in austere environments or anywhere, even here in the United States, it can help you as a life-saving imaging modality, because sometimes it just gives you information that you otherwise wouldn't have unless you put the probe on your patient. And so I hope I've really given you an opportunity to see the incredible ways that ultrasound can really help you better take care of your patients, especially your little pediatric patients. Thank you so much.
All right. Thank you so much, Dr. Levine, for an excellent presentation. As noted in the intro, we won't have a live Q&A session today, but please feel free to send your questions along to Paul Bojarski at paul.bojarski@fujifilm.com. Paul will pass your questions along to Dr. Levine and answer any questions you might have about Sonosite systems as well. Thank you all for joining us today for today's webinar. We'll be announcing some more webinars soon, so keep an eye on sonosite.com/behind-the-scan-webinar for more details. And in order to get there easily, you can scan the QR code that's on the screen right now. Thank you, Dr. Levine, for taking the time to put together an excellent presentation for us. As always, we appreciate you sharing your knowledge and expertise with our audience. And thank you to Paul Bojarski as well for helping out with answering questions. And of course, thank you to everybody else for joining us here today. We'll see you at the next webinar.